have to move to extracorporeal CO2 removal, and I'm presenting the possibility to combine lung and kidney support when dysfunction of these two organs is present. Now, this equation is quite typical. Admission of a patient, he requires mechanical ventilation, he requires renal replacement therapy, and we have mortality increasing with the increase of number of failing score. When you have acute renal failure, you need renal replacement therapy. When you have multiple organ failure, you need multiple organ replacement. But multiple organ dysfunction may require what we call multiple organ support therapy. So renal replacement therapy for the kidney, or most for different organs. Now, there is indication, and I know very little about mechanical ventilation, however, that tidal volume lower than 6 milliliters per kilogram allows lung protection. And the idea of extracorporeal lung support is actually to provide gas exchange without causing volutrauma and barotrauma to the lungs. At this point, conventional ventilation with high inspiratory pressure and high concentration of inspired oxygen may be mandatory in some cases. So experts recommend this low level of tidal volumes. And patients may be of two types. Patients that require renal replacement therapy during lung support, or patients that require lung support during renal replacement therapy. In the first case, you may do dialysis, hemofiltration, ultrafiltration during ECMO, ECHO, DCAP, or in patients in which you need to remove CO2 when they are doing extracorporeal therapy. Now, what I would like to tell you is that in the past, we all know that extracorporeal membrane oxygenation is provided a full substitution of the respiratory need for the patient. But there is a difference between replacement and support, and removing CO2 may sometimes help some patients not to be intubated or to reduce the level of invasivity of the mechanical ventilation. This is the first neonate that was treated with ECMO many years ago, and I remember working together with Dr. Bartlett in Ann Arbor, Michigan on CAVH in patients like this. This has followed with several different improvements, and today's very high flows are actually used in the extracorporeal membrane oxygenation. Now, there are intermediate solutions like the Novalung membrane, in which it was used in arteriovenous mode with a blood flow in the range of 1.5 liters with the capacity of CO2 removal. This is how the ELA membrane ventilator was working in arteriovenous mode. Now they also have a pump, and they use this in a veno-venous mode. They use quite a large cannula in order to provide enough flow. And this has connectors for the extracorporeal therapy. So you can actually access the circulation directly in the extracorporeal lung support circulation, as you can see here. Now, one of the thing to say is that this idea is actually 30 years old, and this paper from Gattinoni in the British Journal of Anesthesiology of '78 showed that actually in hemodialysis and in extracorporeal removal of carbon dioxide, there are some analogies. However, blood flow was mainly the difference. But there is also a kind of a knowledge from our own discipline, because when we started to do high efficiency dialysis with blood flows in the range of 400 and in case 500 mL per minute, we found that we could not use acetate because patients were stopping breathing, because they lost so much CO2 through the dialyzer that simply they were becoming hypocapnic. So the idea that CO2 can be removed through a dialyzer membrane was old enough to suggest that if you use this in a modern oxygen or carbon dioxide exchange membrane, this can be used in association with a CRRT machine. And there are actually studies to show that with blood flow today that may range between 350 and 600. So the additional concept here is to integrate a decarbonizer in the CRRT circuit. And here you can see easily how this small oxygenator, but you're not having as a target to oxygenate blood. Your target is to remove the excess of CO2, in this case, is integrated in the circuit. This is the circuit as it is used today, and at the bedside of the patient is quite simple, as you can see the layout of the circuit. This can be done in association with hemofiltration or simply with ultrafiltration or even as an isolated therapy. And we have now different machines that can actually be utilized. We have presented in the Carta of Vicenza the possibility to homogenize the nomenclature also for these specific therapies, but I don't want to waste time in this moment. I want to show you that different machines today seems to be equipped with this level of technology that make available one more possibility to support respiratory function in the patient. We have different blood pumping technologies, different blood flows, vascular access, different oxygenator membranes, and in some cases there is availability of online CO2 monitoring, as in this case, where there is a kind of measurement by infrared spectroscopy and volume known of flow of air that can tell us exactly how much CO2 is removed from the patient. And this device is quite simple, and it works in a range of blood flows between 350 and 450. I think it's extremely interesting for let's say, not particularly skilled equipped teams to have the possibility to monitor the amount of CO2 that is removed in the system. And this is the case in which you can see the patient treated for 6 days with progressive removal of CO2 and significant improvement after a few days. These are other patients that we treated, patient with H1N1 influenza with respiratory failure. You can see how the tidal volume could be lowered down between 4 and 5 milliliters per kilogram. And you can see how pH was controlled in this patient and how the ultraprotective ventilation could be applied in this case. Also, the control of PaCO2 and tidal volume, again, in this other patient. I would like to see that tidal volume as low as 4 milliliters per kilogram could be applied with a fairly good control of CO2 level. And again, this is the pH control, and this is the peak inspiratory pressure, which they tell me is important, but only anesthesiologists know this. Nephrologists really don't have enough knowledge about this. But nevertheless, the important thing is that the PaCO2 is remained constant under this very low insulting level of parameters. We have a study going on say, 18 subjects in which we let's say, aim at ultra-protective ventilation. We have some preliminary results. I think it's very important information to know that the peak airway pressure during CVVH and DCAP remained quite low. And this is the PaCO2 control, which is quite good. This is the plasma pH in the first 4 patients. And this trial demonstrates so far feasibility and safety. And in a crossover observation, tidal volumes can be reduced safely below 6 milliliters per kilogram. So the idea is that we might transform this type of patient into this type of patient. And this type of patient is characterized by much less comorbidity and better outcome. If you want to know more, please join us on the Cappuccinos on YouTube, and I'm sure that you will enjoy a discussion about this thing. And with this, thank you very much. I think I made it.